Our next speaker is Dr. Cordes. He is the Director of Geriatric Psychiatry, the fellowship program at UTHSCSA, and the South Texas Veterans Healthcare System. He's going to be talking about the Imperfect Interview. So please welcome him.
Good afternoon. Can you hear me okay? Yes. All right. Okay, so like he was saying, I'm Jeffrey Cordes. I am a clinician educator here at the Health Science Center and the VA, and I mostly see patients over the age of 70. How many of you are clinicians? Okay, do all of you see only elderly people? Yeah, some of you? All right, and I don't know, are some of you from, say, social work? Okay, nursing, psychology? Medicine? Physicians, anybody? Okay. Trying to get a sense of who my audience is. All right, let's see. I'm going to try to convey to you some of the things that I teach to people that are in training with me. And I've titled my talk, The Imperfect Interview. Some of you have seen one of these. That was a joke. All right, and in other words, this is how to systematically evaluate behavior in the diagnosis and management of dementia. I have no relevant financial conflicts of interest to report, and if I happen to mention a medication during my talk, you can assume that it's off-label. Okay. The objectives of today's talk is that I want you to understand the key elements of any effective clinical encounter, regardless of specialty or type. That there are barriers to an effective encounter, and that those barriers that we see in an effective encounter or an ineffective encounter give us information, and that information helps to inform us about what the diagnosis of the clinical problem is and how to think about managing it. So let's start off kind of broadly and very simply. Why do we go to the doctor? What is the end being sought? We can have audience participation, right? Okay. All right. I was afraid of that. So what is the end being sought when you guys go to the doctor? Anyone?
Help.
Feel better.
Help with what?
Health.
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 Health, okay. What about it? Well, health will be important. We should go to the doctor every day. So we go to the doctor for...
Get treatment.
To get treatment, right. I guess you could say...
Preventative.
It's simply, yeah, right. So I think those are the two major reasons a person goes to the doctor. First, we verify that we do, in fact, have a problem. We think we have a problem. Let's take it to the expert and see if he thinks we have a problem or she thinks we have a problem, and see what can be done about it, right? And alternatively, sometimes we're not really sure that we have a problem, but we just want some reassurance that maybe I don't have a problem and that nothing actually has to be done, right?
Mm-hmm.
Okay. So like if you go to the doctor for a well child visit or something like that, it's of the second type, or like a athletic physical, right? Just want to make sure that everything's cool and you don't have to do anything special, that everything's all right. Most of the time we go to the doctor because we think there's a problem. So, do any of you ever have like some sort of a medical problem and you don't go to the doctor? Right? So it's not for everything, right? We kind of pick and choose. Maybe we have a cold or a little GI problem or something. We don't necessarily go to the doctor. Sometimes we treat it ourselves right away. Okay. So I'm going to start off with some sort of general conceptual things. Those of you who are clinicians are no doubt familiar with what doctors think of as the SOAP format. And the SOAP is the way we structure the notes that we write. It kind of pains me that in the modern era of the electronic record, this SOAP format is being kind of subtly altered little by little. So if you look at a typical doctor's note these days, there's all kinds of templated things that go in there, right? That totally upsets the flow. There's all kinds of like clinical reminders and key questions that are kind of dispersed throughout the note. It doesn't flow anymore. It doesn't have the right rhythm to it. It's things that are mostly there to satisfy somebody who's going to audit the record, right? Isn't that so? Rather than what's really clinically important. So the SOAP format, of course, goes like this. Most of you are probably familiar with this. There's the note that we write tends to have a flow. The first part of the note is the subjective part. The second part is the so-called objective part. And then we go to the assessment and the plan. Okay, so the subjective part of the note has to do with what is the story? What is the patient or the other informants that are with the patient trying to tell us? What do they see might be the problem? What do they think is going on, right? All that kind of stuff. And where has the patient been before? What has he tried? When did the problem start? What happened next? That kind of stuff, right? You guys are all familiar with that who see real patients. The objective part of the examination is what I, as the doctor, you as the clinicians, observe. This is what we see. This is what we see with our eyes, and hear with our ears, and feel with our hands, and smell with our noses. And I think in the old days, sometimes they even do taste. I've never done that one. Urine taste testing. I don't think that's... but in the old days, they did. That's how they would diagnose diabetes. Okay, so, but also the objective part is also the laboratory tests, the imaging, and any other test results that we have at our disposal. And then what we do is we take the information from the S and the O, and we write our assessment. This is what I think. This is my conclusion based on this information above us, right? Isn't that how it works? It's very clear. This is what the patient thinks, this is what I see, and this is what I think. And finally, the plan is what I did today or what I'm recommending be done next. Okay? It kind of has an order to it. It's logical. There's a flow to it. And the reason I bring this in here is because it's important when we think about what a clinical encounter goes like. So, I titled the talk The Imperfect Interview, right? In order to think about what an imperfect interview might be like, we have to think about, a little bit about what a perfect interview might be. Okay? So, those of you who've actually interviewed real patients, regardless of your specialty or discipline, what would you imagine in your minds as I'm talking would be a perfect interview? You leave that room and you say, whoa, that was a perfect interview. That was awesome. What was it like?
Genuine.
Genuine?
Mm-hmm.
Clear and concise.
Clear and concise. What do you mean?
They say exactly what it is.
Yes.
And you know exactly what it is.
Right. So they're clear. They tell you exactly what their problems are, right? That kind of stuff. What else?
No circumstantial or tangential speech.
Okay. So nothing extra. So just the facts and none of the fluff. None of the irrelevancies, right?
Even your the clinical, the labs or whatever your objective things are very clear and concise, and they're very direct, so that you can make your assessment a good assessment.
Oh, good point. Okay, so nothing ambiguous. No labs that are kind of borderline or iffy. You want it clearly abnormal or totally fine, right? That kind of thing. Okay.
Complete.
Complete. No missing information. No missing data. Have everything there right in front of you. You know what to do next, right? What else? Any other thoughts?
Not a lot of unmet needs that you can't fix.
Okay, so you want to feel as if you know what the problem is and what can be done about it, and that you can do something about it. Yeah. You want to feel effective at the end of this, right? Yeah. What else? If any.
Good rapport.
Good rapport. You want to be able to get along well with the patient, right? Yeah. That's pretty much what I think as well. So I've kind of organized this in a little bit different order, but starting from the doctor's perspective, the perfect interview is pretty much like you guys are saying. He gives all the relevant information and nothing else, right? It's clear. The patient understands all of your questions, right? And when you're getting your objective information, your exam information, he's fully cooperative. He knows what's expected of him, and there's no delays or or problems with any of the things you're asking him or her to do. And then from the patient's perspective, we didn't really talk about that too much spontaneously. People were kind of talking about it from the clinician's perspective, but from the patient's perspective, what are some of the relevant issues? Well, I think the most important thing is this one, that I have it as a start here. It says that the patient needs to feel heard and understood by the doctor. And in fact, that's the #1 thing that we all should strive for when we have any kind of a clinical encounter. The person needs to feel like the doctor, or the clinician. I'm using the word doctor, but think clinician, okay? Really understands what the patient's problem is, and really the only way to do that is to reflect back to the patient what your understanding is. So, that requires a lot of summary and restatement of the problem so that he or she really knows that you've heard. It's not simply listening, it's actually demonstrating to the patient that you've heard. And the better you do this, the better all of the above goes too. They're not distinct processes. And finally, the patient wants to think that your impression, your conclusion is both understandable and credible, right? You want to, what you say has to make sense to them, as is what you're planning to do next. It needs to make sense and it needs to seem appropriate. So I think if you've accomplished these sorts of things from both the doctor and the patient's perspective, then you're getting close to something that we can think of as a perfect interview. So both the patient and the doctor need to be extremely satisfied with this clinical process. Now, it may be, and no doubt you've all experienced a situation that a patient comes in with a problem, you're able to diagnose it, but there may not be enough that you can do about it, right? But that doesn't mean that the process itself can't still be very successful. Neither party says too much nor too little, right? The patient probably doesn't want you to be overly verbose either. And both parties are pleasant, but not too pleasant. So I think probably you saw Dr. Royal a few minutes ago, right? Okay, Dr. Royal is one of my colleagues, and he's one of my mentors and teachers. And when I was a fellow in geriatric psychiatry, I was assisting him in a research project. And we would go out to this clinical site, and we were trying to demonstrate how reliable this certain questionnaire is with patients. So we would alternate first him and then me, while the other of us would sit in the room and do our own rating on this paper form, right? So it happened to be his turn to interview the next patient who comes down for the study. He's doing the interview, and I'm just sort of in the corner filling out my own sheet. And it was the patient I'll never forget. She was, if you can imagine, the famous actress Mae West. Okay, this was what this patient was very much like. So she's like overtly flirting with Dr. Royal, you know, why don't you come up and see me sometime, big boy? Well, he's trying to ask her these questions and go through this questionnaire, and I'm in the corner, you know, doing my same thing. So I was so very glad that it was him having to do it and not me. Anyway, so you don't want the patient to be overly pleasant. You don't want boundary problems. You don't want to be distracted. You want to be able to think and concentrate and do the very best you can. And then the bottom line is that we need to reach a conclusion very efficiently. Like, time is money, right? Time is important. None of us wants to take more time than is absolutely necessary to achieve this. All right, so incidentally, if you're able to achieve something close to this idealized, hypothetical, perfect interview, then in my opinion, that very much suggests that there is no active major psychiatric problem. Okay, and also that there's no significant cognitive impairment, right? So, in one of my roles here at the VA, I work at the memory clinic, and one of my duties is to screen the consults that we get to the memory clinic. So it's not uncommon for us to get a referral to us that goes something like this from the primary care clinic. Says something like this: I have a 52-year-old employed, you know, RN or something, who has complaints about her memory and is wondering if she might have dementia. It's like, well, I can tell you just from the story that there's no way she has dementia, if that's the question you're actually asking. And then we're going to get into that next, because the way they present themselves has a lot to do with what their actual problems are, or lack thereof. So, patients who do have major psychiatric or cognitive disorders have pronounced functional impairment, and that conveys itself into these observable behaviors on your clinical examination. And consequently, they're really not able to give a perfect interview. And the barriers to this idealized perfect interview we were thinking of gives us clues as to what the clinical syndromes are that different patients have. All right. I'm calling this the behavioral exam. It's generally thought of as the mental status examination. Probably all of you have heard of a mental status examination, right? Okay. And that's something of a misnomer, right? The mind actually can't directly be examined. It's not a material thing. You can't measure it with a ruler. You cannot take its temperature. You can't define its dimensions exactly. It's something that we have to infer from the patient's behavior. And consequently, it's really of a completely different kind. What about those of you who are familiar with like physical examinations? You know, when does say the heart exam begin? You know, doctor takes out his stethoscope, and the heart exam begins right when his stethoscope hits the chest, basically, right? And it ends when he takes it off, right? When you tap the tendon with your reflex hammer, it starts there and ends there, right? You know, stick out your tongue and say, ah, the exam begins and the exam ends. In the behavioral exam or the mental status examination, when does that begin? Yeah, from the very beginning, right? Is it when he walks into your exam room? Could be even before that, right? And so it's probably virtually everything that you know about the patient. Yeah. How did the person set up today's appointment? Did he call? How did he get to today's appointment, right? What's his behavior like out in the waiting area? How does he make it down to your exam hallway? How does he conduct himself in the exam room? All of those things are part of your clinical observations. So in some ways, it's a very tricky thing, right? All right. So I've been talking about the mental status examination sort of in general as a general psychiatric issue. Let's shift a little bit and focus more on dementia. So when I use the term dementia, what exactly is that? Anyone? According to DSM-5, if this is the Diagnostic and Statistical Manual of Mental Disorders, and the 5th edition came out about a year ago, and according to DSM-5, if you read all this, you'll get a headache. Okay, so I'm not asking you to do that. I put it up here in small print, but I really don't expect you to read this. Essentially what it's talking about is that there's been a significant decline in cognition from previously, and that it interferes with activities of daily living, and it's not due to delirium or some other psychiatric condition. So it's really quite simple, and can probably be reduced to a sentence something like this. It's an acquired loss of independent functioning due to cognitive impairment. So consequently, a person doesn't have dementia if he's never been independent. So maybe someone with a developmental problem, mental retardation, autistic disorder, Down syndrome, something like that, who's never been independent, you wouldn't characterize as having dementia. And also, you wouldn't characterize the person as having dementia if their independent functioning loss is due to physical impairment only. Okay, therefore, a person with a very severe physical handicap might actually not be demented if he sort of remains in charge. Right? So we're all familiar with the famous actor Christopher Reeve, right? Superman actor. He had a high spinal cord injury and had quadriplegia. I never examined him, but I infer from his life story after that he probably wouldn't have had dementia, right? He was directing movies and writing books and making speeches, right? So I can just speculate that probably in his day-to-day living, he was still very much in charge. He was probably you know, making comments to his attendants, I don't think you've rolled me over lately, I don't want to get a bed sore, what about, have we paid the bills, do we have a backup battery for my ventilator, how are we going to get to the speech I have in Los Angeles, you know, all the travel arrangements. He's probably talking very much like that. So even though he can't do a single thing for himself, he still wouldn't be considered to have dementia. All right, so I'm going to go through some of the features of a behavioral examination that are relevant to dementia. And I'm going to go through each of them one at a time and talk a little bit about them, some of them in a little more detail than others. So what can we infer from a person's appearance?
Doesn't it depend on what stage of dementia they're in? Because in the beginning, you may not see any difference at all.
Right, so some dementias are a moving target. Some of them are progressive. Right, so at different stages of the dementia, there might be different appearances, that's correct. What else?
They may have been neat and fastidious or whatever, and they've let it go.
Right, so someone who previously was very well kempt and appropriately groomed, all that comes in and is no longer that way. That's certainly possible. Other comments about appearance? What about the opposite? What about someone who comes in who is extremely well groomed, shaven, has everything in order, everything appropriate? Does that mean he's not demented?
No.
Why not? Okay, maybe he's not demented yet.
Or as demented.
Yeah. Okay, I heard someone say caregiver. Yeah, is that possible?
Oh, yeah.
Oh, yes, yeah, that's right. So someone can be very well managed and not have dementia, but they are extremely well groomed, right? Okay. What about like neurologic features on the examination? What are some of the ones that might be relevant to our interview and our ultimate diagnosis? Yeah. Yeah, there's lots of things that I would put under the heading of neurologic.
Do like frontal release signs for someone very demented.
Yeah. Right. What about something as simple as hearing? That would be a neurologic finding, right? Hard of hearing, anybody see that? Eh. What about vision loss? Right? And other things that can affect our diagnosis as well might be movement disorders, Parkinsonism, dyskinetic movements, like maybe Huntington's disease, right? All right, so some of the things hemiparesis, right? Half of the body is paralyzed. Do any of those things by themselves prove that the person has dementia? Have you seen anybody with any of those things who doesn't have dementia? It's possible, right? So for every one of those things I mentioned, I've seen someone who actually doesn't have dementia, even with very severe impairment in any of those areas. Like, say, around a month ago, I examined a fellow who has Huntington's disease. He has the genetic abnormality. It's been proven. It runs in his family. And he's kind of jerking around and moving around in the exam room. But he's actually not demented. Functions totally independent. So just because they have a neurologic feature doesn't clinch it that they have dementia, but it might contribute. Okay, what about language? That was your cue. So in our perfect interview, this is one of the essential features, right? Having an ability to communicate with language, right? Yeah. So what if the person speaks another language that the examiner doesn't speak? Right? You could think of that as an aphasia, right?
It would be, excuse me, it would be an aphasia if they didn't speak the same language?
It would be a functional aphasia. Because everything he says, you don't understand. And vice versa.
But if they, I guess I was thinking if they spoke another language, you'd have to get an interpreter.
You would, right?
Right.
But functionally practically speaking, that it's an aphasia until you do.
And you're aphasic too.
And I'm aphasic also. Yeah, we're both aphasic.
Change in their language, where they were bilingual and then they stopped speaking the second language.
Right. You'll occasionally encounter that, right? That they lose one of their languages. Okay. So aphasia is sort of the doctor word we use. So aphasis comes from Greek and means to utter or to speak. And aphasia means speechlessness, or really has come to mean any language disturbance. So the features that are relevant in a psychiatric or neurologic or general medical examination are mostly these listed here. I'm not going to go into a lot of detail about them because just this heading is a lecture all of its own. But of course, language impairment affects your ability to get information from the person and for the person to receive information back from you. Okay, attention, how is that relevant? Yeah, so in one big way is if the person has very poor attention, he might be delirious, and actually that's one of the things that would mean that he actually doesn't probably have dementia, at least doesn't only have dementia.
Would that be potentially related to, if they're not hearing very well, would that have an issue with attention also?
Well, it could. So let's talk a little bit about that. So a person with hearing impairment or vision impairment, let's think of those two kind of in the same general category. So that person goes to the doctor. He's maybe has hearing impairment, for example. And if he can't really hear, basically in the encounter, what he ought to be seeing is something that looks like this. Right? And if I were doing that with you, if I were your doctor and you were the patient, would you just sit there?
No.
Yeah. You would bring it to my attention. You say, hey, doctor, I didn't hear what you said. I'm hard of hearing. Could you write it down? Could you speak louder or something, right? You wouldn't just let it go, right? But a demented person would just let it go. They just kind of sit there. And same thing with the vision impairment. Sometimes it's not that obvious that they have vision impairment. Thank you. Okay, so what about memory? When I say dementia, you say memory, right? When I say dementia, you say. When I say dementia, you say memory. All right, thank you. All right, yeah. So when I say dementia, most people think memory. And now memory is a simple word that lay people, even children, use all the time, but it's really much more complicated than that. Okay. What we mean by memory means many things, and this is only a partial description of some of the terms. But amnesia in Greek comes from the term mnesia, or memory. Amnesia means lack of memory or memory loss. And the most relevant types of memory that I find in my clinical work are these kinds of memory. Let me just quickly go through these. Like episodic memory. Episodic memory has to do with your ability to remember some events in time. All right. So, how did you get here today, sir? Did you have any breakfast today? You were supposed to go to the lab and get your, blood test done. Did you do that? All those sorts of things are episodic memory. Semantic memory has to do with like fund of knowledge, informational kinds of things, right? Procedural memory. Procedural memory has to do with habits, the motor programs that we all learn how to do just by being alive, right? And finally, working memory is sort of, you can think of as sort of whatever is currently active on your computer screen. You know, it's what we can remember for a short time, but not very long and not very large quantities. That helps us get from moment to moment. So, for example, I can tell a patient to remember these three objects: okay, apple, table, penny, for example. And then I might distract him with something, and then a minute later I ask him again, what were those three things I asked you to remember, Mr. Jones? And if he can't remember them, the fact that he could say them back to me gives me some sense that he has something of a working memory, but he's just not laying it down into a longer term memory, all right? And each of these plays a distinct role in our clinical examination. I don't know if I'll have enough time to go into more on this or not, but you know, I wanted to start with that sort of introductory information. All right, praxis. Anybody know what praxis is? Moving? Not bad. I can't hear you. What I say?
Doing.
Doing, yeah, right. Good. Yeah. So praxis is all about doing. It means to act, right? And apraxia basically means an inability to act despite otherwise intact neurologic functioning. So patients have apraxias. There's a whole bunch of different kinds of apraxias that I didn't list, but they've been described in many different ways, and there's a lot of different terms that they use. Visual spatial abilities is sort of a person's ability to orient themselves, to distinguish left from right, to put on their clothing, things like that. Recognition and insight. So, in order for us to have a perfect interview, we were talking about earlier, the patient really needs to understand that he first has a problem, right? That's pretty foundational, right? That you have to understand that you have a problem, and then to be able to describe what that problem is. Some of the patients don't have that ability at all. So recognition and insight are under the general category of gnosia, which is to know something, and agnosia, which is not knowing, right? If you're agnostic, what does that mean? Maybe you're religiously you're an agnostic. Kind of thing. Maybe they don't know, or they're not sure, or they're non-committal, or something like that. They just don't know. All right. So in the same way, we use the term agnosia, and I'm going to skip all over all these and focus mostly on something called anosognosia, which basically means that the person doesn't really know he has a problem. So some dementias, this is a very big thing. Fascinating, actually. What about abstraction abilities? What does that concept denote? Oh, okay, you're right. Okay.
They're not able to connect those types of phrases.
Right. So I think what you're saying, Cynthia, is that there's like this higher ordered thinking, that they're making connections. They're thinking in metaphor, right? Yeah. Are there any other clues during the examination about someone's might have an ability or inability to abstract?
It could be something as silly as, man, it was really raining cats and dogs out there, right, sir? And I'm like, I didn't see any cats or dogs outside.
Yeah, right. So if somebody responds like that, that is not abstract, right? That's not abstract. That's very concrete, right? So that's right. So sense of humor is a real big one. So we commonly say we use humor all the time in kind of simple and subtle ways when we interact with one another, right? It doesn't necessarily encompass telling jokes or doing a stand-up comedy routine or necessarily something like that. But humor is one of the basic things that we use to relate to one another. So patients who take a statement like you gave very literally probably have a lot of trouble with abstract concepts. the amount of activity that a person displays during your examination gives you a lot of information about what their clinical syndrome is, and we'll talk about that a little bit later. But some patients are overly passive. Okay, they have errors of omission. Right? There's things that they should be doing that they do not do. They're overly passive. These are the kinds of patients where you actually have to work very hard to get any information at all out of them. They give you very brief responses, 1 or 2 words, and you have to follow that up, and it's like pulling teeth. The opposite of this is, of course, inappropriate activity. So some patients are overly active or inappropriately active. They have errors of commission, right? They do things that they really ought not to be doing during the examination and elsewhere. What about mood? Different people talk about mood in different ways. The way I'm using it here, I'm talking about not just depression and elation, but I'm also thinking of things like irritability. So some patients get very angry during your examination. Some of them get very angry if you're asking them kind of memory kinds of tests, test questions or whatever. Very irritable, and that affects your ability to do this perfect interview, right? What about psychosis? Does the person have any hallucinations or active delusions that might interfere with your examination? And lastly, executive function. Probably most of you are familiar with executive function, but basically executive impairment refers to someone who has difficulty kind of seeing the big picture, formulating plans, carrying out a sequence of steps, and doing quality control along the way, and following through all the way through to completion, and sometimes abandoning plans before you reach completion. So if you're like me, in the morning I have some idea of what I'm going to try to accomplish on a given day. So far so good? All of you? Yeah. And I don't know about you guys, but very rarely does it actually go that way. Right? Maybe never even. Okay? Depending on how long that list is, the less and less likely it is that it's going to go like that. And some of the things I'm very glad I didn't actually accomplish that I have set out to do. Some things I have abandoned, right, before actually doing them, because a better idea has occurred to me, or a more urgent or important idea has taken its place. Right? All that has to do with executive impairment. So you can think of executive impairment as the CEO of the brain, right? A CEO of a corporation is what, the highest paid person or the lowest paid person? The highest paid person, right? Why is that? The buck stops here, yeah, right. Yeah, probably because it's the most important position, right? The CEO is in charge of the plan, right? And the CEO of an organization is in charge of making sure that the most important things get done first, and that they channel the resources in the right direction and do things in the right order, and that they don't have too many of this and too little of that, and they're trying to make sure things get done appropriately, and that since the world is always a constantly changing thing in place, that there's circumstances change over time, they got to make adjustments. So the really good CEOs make the big bucks because they're effective at this. Right? So someone who's the metaphor of the CEO in the brain, who has trouble with that, also has trouble with his independent function. Okay, so how are we doing on time, Mark?
You're going okay.
How much time we got left? No?
45 minutes.
I got started a little bit early, so I don't want to kill you guys. But, okay, so
I'll speaker's not here yet anyways.
okay, all right. So anyway, so what are some of the barriers to an efficient interview? We talked about some of them already, and then how do they inform our management? So I thought I'd put together a handful of slides that talk about the basic syndromes that we see clinically. There's 4 different general patterns that we encounter. I'll go through each one at a time. The first one is dementia syndrome number 1. You can think of this as the prototype being Alzheimer's dementia. You can also think of it as a cortical dementia, or Dr. Royal and I talk about it as being a type 1 dementia. And those are all synonyms. And an Alzheimer's patient is the most famous kind of dementia. Most lay people have heard of Alzheimer's disease and they have some sense of what it is. And in fact, anytime you say the person has dementia, what does he think? Alzheimer's disease, right? If I say dementia, you say memory. If I say dementia, you say Alzheimer's disease, right? Because it's very common, it's in the media and all that. Now, the interesting thing about Alzheimer's disease is that they have a lot of that anosognosia, that term that I told you before, where they're not really aware that they have a problem. So it's almost inconceivable that someone would go to the doctor himself complaining that he might have early Alzheimer's disease. Usually the person with Alzheimer's disease is like the last one to know. However, as the illness progresses, they tend to have a lot of problems with episodic memory. We talked about that earlier. This is, the short-term memory, the things that have happened in time, that usually recently in time. They have a lot of problems with that, and that interferes with their ability to give you any kind of a story. So they're the kind of person who doesn't even know that he has a memory disorder, that he has functional impairment. He's not even aware of it. He's not even sure why he's here to see you. Usually he wouldn't be at the appointment by himself. As the illness progresses, they tend to have problems in other areas, and at some point many of them have problems with language ability. So they have difficulty expressing themselves, they have word finding problems, but they also probably have a lot of receptive difficulties. So as you're asking a question, or if you're a family member who lives with someone with Alzheimer's disease, what you think you're saying to the person the message doesn't get through quite like that. So probably as you're talking to someone with Alzheimer's disease, many times it sounds like total gibberish. You may be talking about all these things and things he needs to do and giving him information about his condition, but it may come across as and he may nod politely, but he may not really understand exactly what you're saying. They have a lot of praxis problems, which impairs their ability to participate in many of the examinations that we have them do, both neurologic and mental status examinations. And they're frequently irritable, so they often get mad at the test that you're asking him to do. So if you do something called a mini mental state examination, you guys familiar with those? Most people? Yeah. They get real angry. They even simple questions like, what is today's date? Oh, I don't need to keep track of this anymore. Well, okay, well, what day of the week? Oh, I told you already. I don't need to know that sort of thing. I told you I'm retired. And the more you try to press them, the more angry they get, right? Because you're starting to perturb them. And then they don't cooperate, and sometimes you have a hard time even getting them to stay in the exam room. And furthermore, they tend to be what we call environmentally dependent. So they tend to wander around. Sometimes they stand up during your examination. They try the doorknobs. They answer your telephone. They'll do all kinds of things during the examination simply because the environment is enriched with things that they have habits for. These are the kind of patients, anybody who's worked with me will have seen me do the handshake routine. And the handshake routine is basically, I offer them my hand in greeting, and then I just leave it there, just to see what happens. So if I were to do this to one of you, I would shake your hand, and then you would shake it back, and then if I just left it there, that would be weird. That'd be real weird. That's not what's done, right? But if I just kind of leave it there, sometimes they'll put their hand down, but I leave it out there in their space. And I kind of leave it out there as I'm talking to them. And I'll say, turn to the wife, and I just kind of leave it there. And many times the patient will continue to shake my hand over and over. They'll shake it 50 times in a row. Just simply because it's there. Not because it's appropriate. Not because I am congratulating him. Not because I'm saying hello. Not because I'm saying goodbye. In fact, I'm not even looking at him sometimes. It's simply because it's there. Okay, so that's what environmental dependence is like. So interestingly, in spite of the very severe problems that Alzheimer's patients have, there are some characteristics that make managing them somewhat easier. And one of those things is that they tend to have intact procedural memory. So as I mentioned before, procedural memory has to do with habits, doing things a certain way. So if you work with someone with Alzheimer's disease, getting them into a routine can be very important. You know, maybe waiting 20 minutes after breakfast is the time for him to go to the bathroom and sit on the throne a while. If you do it like that, then you're less likely to have accidents maybe during the day. Right? And in fact, if you do this every single day in a very strict, organized, consistent way, he'll start developing habits for that, and he'll almost anticipate having to do that, even though he can't really tell you with words that this is something he has learned and something that's part of his new memory, right? So, knowing what we know about Alzheimer's disease, can you guys speculate with me what some of the things that might not be the best thing to do in managing someone with Alzheimer's disease?
Rearranging the furniture.
All right, okay, you good? Yeah, rearranging the furniture. You know, my dad goes to daycare today. Let's sneak in the house and move all the furniture. That wouldn't work very well at all. Yeah, yeah, let's move. Yeah. Right. That sort of thing would be very disruptive, in fact, if you were to do that. So you want it very consistent. You want it the same every single day. And consequently, even something like going out of town for the weekend can be very challenging for someone with Alzheimer's disease, because they need to know that the restroom is through that door. If you go to like a hotel or something, that's going to look totally different than home. And that can be a real challenge. And I've even had patients, families who go on a long-awaited trip only to turn around right away and come back home because it was just too difficult to manage the person in a setting away from home, even though at home things work pretty well. Okay, other than arranging the furniture, what other things would probably not be a good thing to do in managing someone with Alzheimer's? Choices. Give me an example of what you mean. Give me a choice.
What you want to eat.
Okay.
When you want to eat.
Okay, so saying something like, do you want to go for a drive? Do you want to eat lunch? Do you want to, that kind of thing? Mm-hmm. Yeah. How would you suggest doing it differently?
Have your routine.
Okay. Anybody else? Yeah. How about like it's time for X, Y, or Z. It's time for dinner now. Come with me. Something like that. Rather than giving him a choice, right? Yeah, so Alzheimer's patients, this is a very typical scenario. The family says, Dad, you want to take a bath now? What does he say? No. And then what does he say? No. Well, yeah, he says it again if you ask him again. What else? I already took a bath. That's right. I don't need a bath. I already took a bath. I just had a bath. Right? That sort of stuff. Okay. Yeah. So if you relate with them like that, it's very difficult. So it's probably going to be more successful if you just say, "Come with me," and don't use the word that's fighting words, right? Just come with me, and before he knows it, he's stripped down and in the bathtub. Right? If you give him a choice about it, he'll just say no. Just like those of you who've been around little children, right? How do you relate with them? Okay, Bobby, it's time to get up. We're gonna go to the dentist. let's go to Dr. Bob, and he's gonna give you a shot. You want to go see Dr. Bob and get your shot? No, you don't do that. You just say it's time for us to get ready. Put your shoes on. We got to go, right? And before you know it, he's there, and it's over, right? Let's see. What else might either be unrealistic or not that helpful in relating with Alzheimer's patients? Anything else you guys can think of?
Give a long list of medical instructions to follow.
Yeah. Good. Yeah, so and in fact, almost any kind of instruction is hard for a patient with Alzheimer's disease to follow, right? Right? So I have families, some of them even when they kind of talk about kind of knowing better and they really seem like they understand and they seem like they really get what I'm trying to tell them, it takes them a long time to get past this one. So they tend to get very upset because they told the patient over and over something that he keeps asking, or you know, he'll say, well, you know, where are we going? I told you, Dad, we're going to the doctor. And then a little while later, where are we going? I told you, Dad, we're going to the doctor. I said, where are we going? And a little while later, where are we going? It kind of goes over and over and over like a broken record. So that's very annoying, right? Very frustrating, very irritating if you're a family member or whatever that lives with someone like this. And so it's very hard not to respond in an angry way, right? But to the extent that the family can understand that the person has terrible episodic memory, he doesn't remember that he's asked this question 17 times already. If he did, he wouldn't be asking you again, right? He's not deliberately trying to annoy you, most likely. So helping them understand what the nature of the patient's deficits are can really help them a good deal. So in a way, having terrible episodic memory can sometimes be used in an advantageous way, right? So for example, some patients tend to want to go somewhere. Maybe they want to go to the store, or they want to go back home, even though they're at their own home. You know, so families say, yeah, but Dad, you've been living in this home for 27 years. This is your home. What are you talking about? And he just gets angry because he wants to go home. I want to go home. I want you to take me home. When are we going home? When are we going home, right? Because, the explanations you've given him over and over and over again don't sink in because he has terrible memory. He has terrible episodic memory. So coaching families to not get angry themselves and to work on better strategies in responding to these problems can be very helpful. For example, since they have terrible memory, oftentimes a satisfactory response can be thought of that they can use over and over again. For example, you might say something like, Dad, that's a great idea. Right? That is a great idea. Wouldn't it be great if we could go home later today? Right? Have I lied? No, I haven't lied, right? And how do you think that would sound rather than, no, Dad, you are home already. What are you talking about? You've been in this house for 27 years. Right? Which one do you think goes over better? The first one, right? That's a great idea. Wouldn't it be great if we could go home today? I bet you'd love to see your sister again. He would, even though she's been dead 15 years. Right? I mean, he would. It would be great if he could see her, right? So I'm not really lying. I'm using sort of happy, pleasant, positive thoughts as I'm talking with him. And then you can kind of use that sort of strategy over and over again because just like the other information, he doesn't really keep track of this either. And sometimes that can be very soothing and placating and kind of get you past it, and then you can kind of change the subject and it's a new day. Right?
You know what also too, you might be able to use that same strategy. You know, we can go, let's get a bath first. You know, or doing something that you haven't to do, right, so that we can do that later. But by the time you finish doing what you really need to do, they probably forget.
Yeah, that's a good point. Yeah. So yeah, that's right, Dad. If you want to go home, then you most definitely need to have a bath first. Let's get that bath done, and then at the end of the bath, maybe the second part of that is out of mind. Yeah, that's a good point. Let's see. think those are the major points I wanted to make with Alzheimer's. Does anybody have any other comments about that? Go ahead.
I guess just correcting them if they say that it is 1941, let them think it's 1941 and just go with it instead of arguing that it's 2014.
Well, yeah, that's a good point. So you got to kind of think, oh, well, what's the upside? If I correct him, does he get mad?
They get angry.
Yeah. Does he get angry if I correct him? And then maybe it's not worth it. If I correct him and he even goes along with it, will it even stick and sink in, right? I mean, maybe 5 minutes later he still thinks it's 1941. Yeah. So trying not to be overly frustrated yourself is quite important. Okay. Let's move on to the next dementia syndrome that we commonly see. This is the prototype of this is vascular dementia. So vascular dementia patients are really quite distinct from Alzheimer's patients. In general, they don't really see that they have that much of a problem either, actually. But they are simply unaware of it, and it just doesn't seem very important. The big word with vascular dementia is that they have terrible executive functioning and they're very passive. So these are the patients that mostly just kind of sit around 24/7. Their families often wonder if the person might be depressed, because the patient's families know that people don't do very much or sometimes depressed. Depressed people don't do anything, and therefore this person must be depressed. But oftentimes they have no mood symptoms of any kind at all. But they simply sit on the sofa all day long and don't really do too much. They mostly have reasonably good orientation. They might be off a little bit on the date or the exact day of the week or something like that, but they're generally fairly well oriented. They are frequently irritable also, so that they would much prefer just to be left alone on their sofas and not pestered. If they happen to have had like a certain large stroke-like episodes, then they can also have a lot of impairments in other areas, maybe hemiparesis or something of that nature. Their good qualities are that they tend to have a memory that's promptable. So unlike the Alzheimer's patient who, after distraction, really can't remember anything that you just said, no matter how hard you try, no matter how many cues or hints you give, someone with a vascular dementia mostly can recall what you have said if you give him a hint. So they don't have the same kind of amnesia problem. They have a sort of a retrieval problem. They have a sort of a filing system problem. They can't really find the memory, but if you say it's in drawer A, folder number 3, then they can find it. That's an analogy. Okay. And they also have generally intact procedural memory, but they have such difficulty with executive functioning that they really can't handle multi-step tasks. So they can handle maybe one thing at a time. Dad, it's time for you to put your pants on. Puts his pants on. Dad, now it's time for you to zip up your pants. Okay, now let's put your socks on. Now let's put your shoes on. One step at a time. Versus if you just say, it's time for you to get dressed, we have a doctor's appointment. Doesn't get done. All right. So the good thing about vascular dementia is the person is mostly, in important ways, kind of still in there. He tends to recognize his family. He has relatively intact language in most cases, and is relatively good in some areas, but still really quite dependent and requires others to look after most of the IADLs. All right, dementia symptoms. Wait, so we've touched on some of these things. If you're managing someone with vascular dementia, what's the best way to deal with them? These are ones who have errors of omission, right? Things that they should be doing that they don't do. What would you coach the family to do to manage these cases better?
Give them more cues.
Uh-huh. Right. Basically, that's it. It's all about prompting, doing things simply, one step at a time. breaking things down and doing it like that and being more successful. Okay, well, we'll go ahead and move on to the next one. I'm not sure how we're doing at the time.
Yeah, up to 15 minutes if you want.
Up to what?
15 minutes.
15 minutes, okay.
If you want.
I'm not going to do that to them. All right. So the next dementia center, did you guys talk about frontotemporal dementias earlier today?
Yes.
Okay, then you can teach me. What did you learn? What did you learn? So what is a frontotemporal dementia? Disinhibition, okay. Yeah, so patients with a frontotemporal dementia, they are really difficult. I'm not sure what your previous speaker told you about them, but in my mind, they remind me a lot of little children in the grown-up body. Okay, so they tend to be very disinhibited and very active, but inappropriately so. Okay, and they're a fascinating thing because unlike most dementias, they don't necessarily have much memory trouble at all. So sometimes their memories are totally intact. Okay, and I can give you a number of case vignettes of people with frontotemporal dementia, but they're fascinating. So one of them I had, I would tell the residents, okay, we're going to go in, this is an outpatient clinic, we're going to go in, and I don't want you guys to say anything, okay? You just follow my lead. We're just going to go in there. So we go in there, I have maybe 2 residents with me. I sit down, and the patient just takes it from there. I just stare at him. I don't say hello. I don't ask him a question. I don't do anything whatsoever, and he just starts out something like this. Oh, hello, doctor. I see, I like your tie there. Did I ever tell you that I had a tie that looked just like that? It had stripes that went over here, and I wore it, and I went to work when I went to work, and then over at the bakery. And at the bakery, did I ever tell you at the bakery, for 10 minutes. And I'm just staring there. I'm not staring at him back. I'm not nodding. I'm not going, that's interesting. I'm not having him go on, tell me more, or anything like that. I'm just kind of staring at him blankly. And he can go on, going and going and going and go without ever stopping, just because he goes from one thought to another. Whatever comes to his mind comes out of his mouth. This very same patient happened to live not far from where I live. And I was at the grocery store one time. So I don't know about if you guys know the rule, but if you see a psychiatrist, you don't want everybody to know that you see a psychiatrist. Okay? All right? It's like private information. Okay? So I'm at the grocery store. I'm there here with my 12-year-old daughter or whatever, and I see this person streaking towards me out of the corner of my eye. And the same guy comes up to me. Oh, hello, doctor. And I'm like, hello. And he puts out his hand, he's shaking me. Is this your daughter? Yeah, thanks. And I'm just kind of trying to get away from him and trying not to disclose what he's apparently not trying to hide. So those are examples of what a frontotemporal kind of person is. Another one that I had, this was a guy in his 50s. Who had a couple of children who were college age, maybe 20 years old or so. And this was maybe a year or 2 before cell phones were everywhere, so maybe 10 years ago, so not everybody had a cell phone. So his children's friends would still call home and leave messages. It's hard to imagine now, right?
Yeah.
But this is the way it was. So my friends would call home and leave a message. He'd answer them, like, hello, and they would say, this is so-and-so, can you tell your daughter that we're going to meet at the movies at 7 o'clock tonight at the whatever cinema, right? And he'd say, oh, sure, I'll tell her. And he'd hang up. And then, of course, he wouldn't tell her. Not because he'd forgotten, it just didn't occur to him to tell her. He didn't write it down. And the next day, the friend calls his daughter and says, well, where the heck were you? I left a message with your dad, and we were going to meet at the movies tonight, last night. And she says, well, I didn't get the message. And then she says, Dad, did Janie call? Oh, yes, she called yesterday. She says you were going to meet at the movies at 7 o'clock on Friday night. And then she says, well, hello, why didn't you tell me? Right, it's kind of like that. So he would keep answering the phone over and over again. finally the family had to disconnect the phone and leave it only on an answering machine because he wouldn't write down the messages. They'd say, Dad, you need to write down the messages. And he just couldn't ever do that. So that same fellow, he would be sitting in the bathroom off of the living room, sitting on the toilet having a number 2, and he could hear that the family was having a conversation in the living room, and they would say something that he would want to respond to. So he would stand up off the toilet with his clothing around his ankles, and walk out into the living room naked. Because he wanted to make a point to what somebody commented. See, he has trouble finishing one thing and starting another and keeping track of everything. So, but it wasn't a memory problem. You could ask him, what did I tell you to do? And he'd say, you told me never to do this anymore. You told me to always take a message every time the telephone rang. Well, those of you who have children can relate to that, right? What did I tell you to do? You told me never to do.
That's true.
Yeah. So anyway, so these frontotemporal cases are very challenging. They require a lot of skill, and sometimes it's really difficult for them to be managed. But anyway, I think you would be able to recognize that kind of a patient. They're not real common, but when you see them, they're really unforgettable. So given their deficits, how would you relate with them? What would maybe be the better way to relate with them?
Trying to lay boundaries for them, like guidelines, like we had a gentleman that we had on service that liked to be inappropriate with the female staff, so we put male staff in. So we just kept trying to tell him, touching is bad, looking is okay. Touching is bad, looking, so we just would keep on and on and on and on. So he would, and then so we would ask him, so what's bad? Touching.
Right. Yeah, so it's not impossible, see, because his memory is relatively preserved. His language ability is okay. When you're talking to him, he understands, so it's not impossible for that to work. You talked about some of the environmental things. So, you know, if he has female attendant, he grabs. If it's a male attendant, he doesn't.
Right.
So sometimes it's as simple as that. So the environment around a patient is very, very important. And if I have time to do one more, you think?
Sure,
Mark?
sure.
We'll do one more. All right. So the last syndrome is the Lewy body syndrome. The Lewy body syndrome is probably the most nebulous of them. It's I'm not even sure that we have reached a consensus about exactly how this condition can present itself. However, they have a lot of very challenging problems. One of them is that they have a lot of attentional difficulties. They have what are known as spells, or they have sort of fluctuating attention. And some days they seem clear as a bell, and other times they're really quite confused. If you see them on a good day, they look totally different than yesterday when you had a bad day. Doctor, you should have seen them then. They have associated features that make them real challenged to deal with, including Parkinsonism. So they tend to have kind of a shuffling gait. Some of them have a bad tremor. They tend to have hallucinations and delusions. They tend to fall down a lot. You guys familiar with the REM sleep behavior disorder? Everybody? Anybody talk about that today? No? Okay. So REM sleep is rapid eye movement sleep. And during the stage of sleep, rapid eye movement sleep, that's the stage of sleep where we have most of our dreaming. And in the normal state, we're supposed to be paralyzed. So that's why most of us, when we're asleep and dreaming, other people really can't tell that by looking at us. Okay? With the REM sleep behavior disorder, that paralysis is disrupted in some way, so that people tend to enact their dreams, act out their dreams. So maybe they're running in their mind, and then they're kicking their legs, or they're fighting with someone, so they're grabbing their wife in bed or whatever, right? So that's the REM sleep behavior problem. So that is a real challenge if you have to live with these persons. Interestingly, of all the dementias I've talked about so far, actually they're probably the ones that respond the best to this off-label cholinesterase inhibitor medication, which is mostly used in Alzheimer's disease, but probably works better in Lewy body dementia.
What would be like what would that look like you're an amenda?
That would be
Eris,
ERISA, Exelon, galantamine, those kinds of things. Yeah. Okay, so in the interest of time, let me just kind of wrap it up here. So we've talked a little bit about what a perfect interview looks like, and if you have a perfect interview, probably you can be pretty confident that the person doesn't need to see a psychiatrist, right? If they have problems with their interview and that there's a lot of barriers for you to communicate, for them to understand, for them to express themselves, for them to conceptualize the problems that they have, all of those things we were talking about earlier, then that suggests that there's some kind of a problem. It may not be a cognitive problem. Sometimes it can be something like a personality disorder, right? That happens. Bipolar disorder, schizophrenia. But the barriers that you see in your examination are reflective of specific clinical syndromes. And if you can distinguish one from another, it gives you knowledge about what the diagnosis is and also what might be the better way to manage each of the clinical problems. Questions or comments?
Can it be mixed? You know, like the,
sure.
The dementias?
Yeah, I'm talking about this as if you can only have one kind, right? But the truth is, persons can have more than one style, and they're really kind of hard to distinguish from one another then because they have overlapping features.